following video will review particulars of performing laser interstitial thermal therapy in areas adjacent to eloquent structures. LIT is a minimally invasive stereotactic technique that causes tumor ablation using laser thermal energy under real-time MR thermography. LIT has shown to be efficacious in patients with deep-seated glioma, radiation necrosis, brain metastases, and epilepsy. Particularly useful in lesions involving eloquent brain regions, such as primary motor area, sensory area, visual, auditory, and language areas. We have previously shown, however, that overlap of the treatment lines with the corticospinal tracts can result in a significant new postoperative deficit. The following case will illustrate the technique that can be used to minimize potential injury to the descending corticospinal tracts or any other eloquent cortical or subcortical areas. Our patient is a 62-year-old right-hand dominant gentleman with a history of metastatic melanoma of left cheek that was initially treated with surgery. 23 years later, he presented with a seizure and was diagnosed with multiple brain metastases. He underwent whole brain radiotherapy with gamma knife boost to largest lesions. 2 years later, he presented with right-sided arm and leg weakness and was diagnosed with radiation necrosis. He underwent hyperbaric oxygen treatment followed by several cycles of bevacizumab and experienced transient improvement in his symptoms. However, 1 year later, he presented to our center with gradual onset of recurrent symptoms of worsening right arm and leg weakness. MRI brain was performed that revealed left-sided enhancing lesion in centrum semiovalle region in close proximity to corticospinal tracts. There was significant amount of perilesional edema. To estimate the location of the lesion relative to the eloquent cortical fibers, diffusion tensor imaging acquired in 12 different directions with fiber tracking protocol was used. Location of the tracts was computed in BrainLab iPlan software, and a three-dimensional rendering of the descending corticospinal tracts, arcuate fasciculus, and the lesion was modeled. Next, a trajectory for fiber insertion was planned in such a way to avoid injury to the corticospinal tract or arcuate fasciculus. Once the plan was ready, it was uploaded to the workstation in the operating room. Under general anesthesia, the patient was then positioned supine with the left shoulder roll with the head turned to the right. MRI-compatible Doro head clamp was used to secure head position. Scalp fiducials were then applied, and a pre-procedure registration volumetric MRI scan was acquired and fused with the preoperative studies. Once the scan was completed and the location of the head was registered relative to the reference frame, the location of the entry point for the predetermined trajectory is determined. The scalp is then prepped and draped in the usual sterile manner, and BrainLab VarioGuide system is locked in position according to manufacturer's protocol for our trajectory. 1 to 1.5 centimeter incision is then made through the skin all the way to the bone, and a burr hole is drilled using a pneumatic drill. We use 2 subsequent drill bits. First, a sharp tip drill bit to prevent skiving to ensure accurate trajectory. We use this drill bit until it is well seated in the bone. We then switch to the drill bit with a duller and safer tip to minimize damage to brain parenchyma. Once the burr hole is completed, dura is opened using Kelly's probe following coagulation. A dilator probe is then used to widen the dural opening and the initial tract. Following that, stereotactic biopsy is performed and the samples are sent off for frozen and permanent pathology. It is important to make sure that the biopsy tract is filled with saline at all times to avoid formation of air pockets in brain parenchyma, as it will interfere with future laser ablation. Once biopsy is performed, the brain needle is withdrawn. Following that, skull bolt is then secured into the burr hole along the same trajectory. The robotic Monteris arm is then attached to the steel bolt according to manufacturer's direction. The length of insertion of the laser probe is then adjusted based on the stereotactic coordinate plan. It is then important to ensure that the laser fiber is functional by observing laser light upon a laser activation before advancing the device into brain parenchyma and securing it in place. Once the laser probe is advanced, the patient is then positioned in the intraoperative MRI scanner. A volumetric MP-RAGE scan is first performed to determine the exact location of the fiber within the brain parenchyma and in relation to the lesion. The scanner is then set up for the thermography scans. Prior to initiating the ablation, Preoperative MRI scans with overlaid corticospinal tracts are imported into Monteris and Vision software. Intraoperative MRI scan is then fused to the imported preoperative MRI scan of the descending fibers in relationship to the laser probe. The ablation is initiated. Side-firing probe is used to direct the area of ablation in the direction away from the corticospinal tract. Thermal damage threshold lines are used to monitor the extent of ablation. The yellow line corresponds to the area that was exposed to 43 degrees Celsius for 2 minutes, whereas blue line represents the area of tissue damage that was exposed to 43 degrees Celsius for 10 minutes. Yellow and blue tissue damage lines are constantly monitored throughout the ablation to ensure only minimal overlap with the corticospinal tracts. During ablation of a lesion located away from the eloquent regions, the goal is to have the entire lesion within the blue tissue damage threshold line if possible. And during the ablation of a lesion located near the eloquent region, the goal is to keep eloquent area outside of yellow line as much as we can. Here, because of close proximity of descending motor fibers, the ablation is directed away from the fibers. The probe position is adjusted to maximize lesion coverage along the axis of the fiber. Once the ablation is completed, the areas of damage are analyzed and recorded. As you can see in our case, there is minimal overlap between eloquent and treated areas of brain tissue as outlined by the yellow and blue tissue damage threshold lines. Once the ablation is completed, the patient is withdrawn from the MRI scanner. The laser and the holder for the laser are removed to expose the bolt attached to the skull. The bolt is then removed and the incision is rinsed out with copious amounts of tissue sol or saline, and the skin is closed with 4O Athlon sutures. An MRI brain is obtained within the next 24 hours to determine the extent of tissue damage as a result of laser ablation that is highlighted on the T1 weighted image with gadolinium contrast and outlined by circumferential ring enhancement. Our patient has done well postoperatively, and the patient had slight transient worsening of proximal muscle function that has recovered to pre-op status by postoperative day 2. In conclusion, LIT is a safe and feasible minimally invasive option in patients with lesions near eloquent areas. Advanced techniques of fiber tracking and the ability of importing fibers to the treatment software could result in maximizing ablation while preserving function even in lesions close to eloquent areas and important fiber tracts.